Professor Dinesh Bhugra, CBE, has been the past president of Royal College of Psychiatrists from 2008 to 2011, the past president of World Psychiatric Association from 2014 to 2017, and the past president of British Medical Association from 2018 to 2019. He is Professor Emeritus of Mental Health and Cultural Diversity, King's College, London. As president of WPA, he led on and crafted 30 position statements on various topics, including characteristics of a good psychiatrist, some of which have strongly influenced policy in governments around the world. He established presidential task forces on child abuse and neglect, interpersonal violence, prisoner mental health care, migrant health care, LGBT populations' mental health care, and those of people with intellectual disabilities. He created programs for mental health promotion and appointed goodwill ambassadors from Bollywood and Hollywood, along with patients and religious leaders. He established 6 WPA collaborating centers in different parts of the world to share research, policy, and training. As chair of the Mental Health Foundation from 2011 to 2014, he produced reports on future of mental health services and psychiatry's social contract. He is on the board of Sane and Psychiatric Research Trust Charities and chairs the Doc Health Charity, which is jointly funded by the BMA and the Royal Medical Benevolent Fund. He is the deputy chair and non-executive director of Tavistock and Portman NHS Foundation Trust. He has authored or co-authored over 500 scientific papers, chapters, editorials, and 40 books. Several of his books have won awards and gone into multiple editions and translated into Mandarin and Japanese. He is the editor of the International Journal of Social Psychiatry and International Review of Psychiatry. Good afternoon, Professor Bhugra. On behalf of the World Psychiatric Association, I welcome you, sir, for this series, Meet the WPA Leaders. It is indeed a great honor and privilege to have you with us today. So you have served as the past president of WPA from 2014 to 2017. How did you find this experience, if you could kindly share with us?
Thank you very much for inviting me. It's a pleasure to join the august group of individuals who contributed a lot to the world psychiatry. I was president from 2014 to 2017 in 3 years. To start with, I think it's important to bear in mind that World Psychiatric Association is needed for a number of reasons. Firstly, it's a global organization where examples of good practice can be shared, where people can learn from each other, and particularly the richer so-called Western Anglo-centric or otherwise countries can help develop ideas, services, training, research in countries which don't have access. Regrettably, many a time, the organization has not been able to deliver on that. In the 3 years of my term, when I was elected in 2011, and I had to present my action plan. And there were several things that I mentioned in my action plan, which were to do with, firstly, creating an international diploma for psychiatrists and for non-psychiatrists, so that reasonably uniform standards of training, learning, teaching can be applied across the globe. I also set up 5 presidential task forces, and these included topics like interpersonal violence, child psychiatry, prisoner mental health, etc. But in addition to that, I think over my term of office, I was fortunate enough to create something like 21 position statements, which included things like qualities of a good psychiatrist, to sustainability, to conversion therapies for LGBT individuals. And one of the learning points at that time was that in many countries, guidance from an organization such as World Psychiatric Association can help improve the situation, improve training, improve awareness, and help reduce stigma. I was able to establish collaborating centers, the WPA collaborating centers, which was set up in 6 places around the world. And some of them were aimed for training, others were aimed for research, and others were aimed for policy developments, etc. In addition to that, in that period, we appointed Avdesh Sharma as public education lead for the WPA, and with him, we appointed 6 goodwill ambassadors from around the world. We had people like Sister Shivani, Suresh Oberoi from Bollywood. We had Kunal Nayyar from Hollywood. We had Vanessa Cameron from London, among others. And part of their task was to convey to people about myths of mental illness and to be able to work with them. So there was quite a lot of work done in terms of, in addition to the position statements, there was also joint statements with national organizations, including Indian Psychiatric Society, when we had the joint meeting in Kochi in 2011, I think. No, I apologize. You may have to edit that out. We had the joint meeting with Indian Psychiatric Society in 2014, and we issued a joint statement. We similarly had joint statements in Philippines and Dominican Republic, in Romania. So you can see the countries which needed support, needed the presence of WPA at various levels.
Thank you, sir, for discussing the position statements and outlining some of the various projects that were undertaken during your term. But I am sure that along with the opportunities that you had in the 3 years, there were surely many challenges as the president. So please tell us about these challenges that helped you to grow personally and alongside take the organization forward.
I think, as you say, I mean, the key question is, what's WPA for? Who is it for? What does it stand for? And what does it do? Unfortunately, it has not been able to deliver its full potential for a number of reasons. And we all know the reasons, and I'm not going to go into that. The challenges are quite often, because it's a small executive committee representing different interests, different parts of the world, different cultures, which has challenges of its own. It has a very small administrative support. So part of the challenge really is that the institutional memory tends to disappear, and there's no continuing program of activities. There are presidential plans, and there are, as I said, you set your own agenda for what you're going to do for 3 years of your term. But it needs to continue building on some of the hard work that has already been done. And inevitably, when you're starting afresh, you take first year learning the ropes, second year to do anything, and by third year, it's time to move on. So there is that challenge. There are challenges in different countries, their resources, their health services, and how do you try and support them? And one of the big challenges for me, for example, when I decided to set up position statements, was to say, well, this is globally agreed position on. We were not trying to produce therapeutic models. We were trying to produce more policy suggestions. And, just to take one example, we were approached by colleagues in Indonesia about lesbian, gay, bisexual, transgender individuals and how they were being, the conditions were being put back into psychiatric diagnosis, that these people were mentally ill rather than being normal variants. And Royal College of Psychiatrists in the UK issued a statement, American Psychiatric Association issued a statement. We developed a statement and issued it, and that reflected to the policymakers that what the international position is. Similarly, we produced a position statement on managing suicidal risk and managing suicide. And in a meeting in Vilnius in Lithuania, I was fortunate enough to meet the health minister, and we chatted about the position statement. We gave them the position statement, which ended up being the basis for their national policy. So I think those are the kinds of challenges that we need to be taking on board. WPA is not and should not be about travel and visiting countries and collecting air miles. It's about supporting people who need help. In most low-income countries, mental health does not appear on the agenda. Even in a country like India, expenditure on health is less than 1% of GDP, whereas in America, it's 21%. So how can you provide services, and the pressure on services and pressure on training and pressure on other mental health professionals? So those challenges need to be really dealt with at an international level to create a collegial view of policies, of dealing with policymakers to support them to improve services for people with mental illnesses. And that's what should be the main agenda.
This takes me, sir, to the next question, the issue which we would all like to understand from you. As a leader of WPA, how did you find your experiences leading the profession from an international perspective, as there are so many variations in service delivery, in understanding and acceptance of mental illness in different communities. How did you develop an unified view across all the international medical societies so that patients and their families received consistent care?
I think one of the major challenges really is to understand, because different countries have different health systems, different resources, different levels of training. And one of the reasons why I wanted to set up this diploma was that, we were learning that in many countries, you do 6 months of psychiatry posting, training, and you're a psychiatrist, whereas in countries like the UK, you have to do 7 years. So what's different? So trying to create a sense of professionalism, a sense of what are the requirements to be a good psychiatrist, what does it mean? So it's really an organization like WPA is well placed to deliver that. I'm not sure I've answered your question.
Professor Bhugra, from your talk today, we are getting a very clear understanding that there cannot be an uniform policy across borders, as the service requirements in different countries are different, the health economics are different. Thus, no one model may be able to fit all the nations in providing streamlined care.
I think that's absolutely right. My anxiety quite often is that, we just try and impose Western models of care to countries which see mental illness in very different ways. I mean, quite often you will know in your clinical practice that when people come with psychiatric disorders, it's a mixture of physical and psychological psychiatric symptoms. And to try and just separate in a Cartesian way and then impose that on rest of the world is utterly unfair. So as a cultural psychiatrist, I believe in cultural relativism, and we should be learning from each other. We should be very clear about what is needed. And we should not be enforcing that the Western models are the best. They're not. They're just one form of delivery of treatment, and it depends upon resources. And again, I mean, there is considerable evidence from around the globe that there are examples of good practice, working with NGOs, working with voluntary agencies, working with shamans and hakims and religious leaders. And we should be sharing those examples of good practice. We should be learning from each other. And I think that should be the basic function of WPA, to try and create that dialogue, to try and create that sense of belonging and purpose.
Having served as the president of WPA, the AFPA, the Royal College of Psychiatrists, the British Medical Association, so no one better than yourself will be able to help us understand and recognize that models of different practices are varied, and clinicians have a greater responsibility to judiciously decide what is the best service pathway for their patients. So over the years of experience across the span of your career from India to UK, and having held the top offices of many organizations, do you think the needs and opportunities of our profession has changed over the years of your association?
There's no doubt that services have changed. Practice of psychiatry has changed. I mean, let me just take UK as an example. All my training was in asylums. But when I was appointed consultant as academic senior lecturer, my first consultant job was working in a community mental health team. I did that for 2 years, and then I moved on to community rehab team, and then I moved to intensive care unit, and then ran a psychosexual service for a number of years. What has changed in the UK, for example, from asylums to community, and now increasingly there is services are home treatment, crisis resolution, etc. So the focus is shifted from asylums to community to individuals. And that is likely to continue because with newer medications, newer interventions, people are more likely to be treated at home. And I think that makes a lot of difference. But one of the lessons, in a way, is that in many countries, the burden of care for people with mental illness lies on the carers and the families. And that shift has become much more prominent in the recent times. There is a tragedy in psychiatry that we keep swinging between social psychiatry and biological psychiatry, and somehow as if they don't talk to each other, which is ridiculous because we know that social factors affect mental illness, mental health, mental well-being. They affect our physical health in things like social determinants, poverty, unemployment, overcrowding, lack of green spaces, geopolitical determinants which affect rates of migration, which then affect migrant health and well-being. And that, to me, is an acknowledgement of the interaction between physical mental health and social factors. And we can't just isolate it. This is, biological, and we don't need to do that. And the other thing that has changed is that more and more people are becoming aware of cultural differences. And we know for the first time in DSM-5, there's cultural formulation. Even in a place like America, they're beginning to recognize that there are cultural differences, both in terms of presentation, in terms of help seeking, in terms of response to medications and psychotherapies. So there has been a major shift. And certainly that has also impacted upon training, that more and more people are doing a mix of rotations and training posts, etc.
Professor, I'm sure you realize that sometimes your name is intricately woven with the transcultural psychiatry, as you've done so much of research in this field. Alongside, you've always championed the concept of integrating physical and mental health care in the same pathway. But there are many times when different specialties, different professionals, we don't talk to each other. But we should. Otherwise, the services become fragmented in patient care delivery, and our patients are the ones who gets affected. Sometimes, unfortunately, psychiatry is seen as a Cinderella service. Now, this is a global problem in communication between specialties. What steps, sir, should we personally take to bridge this gap and reach out to colleagues of other specialties?
I think that there are a number of challenges here. I mean, we don't look at other healthcare systems, the Greek system, the Chinese system, Ayurvedic system. And when you read about Ayurveda, it is about mind affecting body, affecting mind, which are affected by diet, which are affected by environment, which are affected by relationships. So there is much more holistic model. And one of the big frustrations that I have had is the Cartesian mind-body dualism. When Descartes described body and soul. And, the church said, doctors can deal with body and soul is the church's problem. Post-Cartesian followers became much more rigid on that. And that's where alienists, as psychiatrists were called, and doctors didn't talk to each other. And having asylums also meant that you were out of sight, out of mind. And in addition to all those problems, there were problems of stigma. And stigma also included self-stigma. And, how many times would you in a party tell others that I'm a psychiatrist? And I think we need to take pride in what we do. We need to take pride in what we do for a number of reasons. Psychiatry is, to my mind, the most complex medical specialty. Where else would you bring mind, body, sociology, anthropology, spirituality together to make sense of the patient's experiences and then treat them accordingly? Where else would you incorporate pharmaco and psychotherapies to try and understand the patient's inner world and outer world, which includes family, tribe, kinship, culture, society, etc.? So one of the big challenges really is, how do we educate doctors? Doing 2 weeks of psychiatry in your 4th year medical school is just not good enough. Psychiatry should be taught from day one of medical school, along with anatomy and along with physiology. Psychiatry needs to be an integral part of medicine. If you have osteoarthritis and you're not recovering or you're in pain, how do you deal with it? Painkillers can only do so much. Physiotherapy can only do so much. How do you interpret that? How do you do motivational interviewing? How do you do supportive psychotherapy? And that should be part of every doctor's job. And it's all our responsibilities to try and influence curricula in medical schools, in postgraduate training, whether you're doing surgery, orthopedics, dermatology. We know, if you have a chronic skin condition, you're likely to suffer both physically and mentally. So we need to change the way we train the next generation of doctors. And it's going to take a generation or more to bring about that equity, which should be at the forefront of our policy making.
Sir, I'm feeling so much positive now, earnestly hoping that within another generation of psychiatrists, we should be able to reduce this gap and have adequate number of psychiatrists to cater to the mental health of needs of our population. This fundamental message you've given us should reach every medical school, every university, every deanery, and to everyone who is responsible for the medical curriculum designing, that psychiatry should no longer be only seen as a short placement, but seen as a subject that needs to be taught from day one, integrated and woven into each of the semester curriculum. This message from you, sir, goes out very strongly from WPA as part of your interview today. Finally, sir, what will be your message to the future leaders of WPA to help this organization further in its progress towards excellence?
Two things. Well, maybe not two things, maybe more than that. I think firstly, we need to train psychiatrists to be advocates for our patients, their families, and their carers. We need to focus on public mental health, which is really ignored. And I think if WPA has to succeed, then people going into those positions need to have certain vision. They should not be going in because they want to travel and see the world. It is absolutely vital that we recognize differences in countries, differences in healthcare systems, differences in training, differences in languages, differences in cultures. And remember that one size does not fit all. So we need to modify our approaches. We need to make sure that WPA is in a position to share experiences which are positive, which are good, which improve patient care. It's not about Western countries, allopathic systems having all the answers. It is sharing good practice. And no matter how much we moan and groan, we will never have enough resources. And as social disparities change, as social determinants change, rates of psychiatric disorders are going to go up. Services will need to keep up with those. Resources will not be enough. So we need to think outside the box. We need to provide leadership to countries which are struggling to deliver services which will be accessible, which will be acceptable, and which will be used by individuals who need them most.
Thank you, Professor Bhugra, for a wonderful interview, sort of telling us very pragmatic points about the current status and the future of psychiatry from the world scenario, really.